You're welcome to this lecture on drug distribution. Drug distribution. My name is Dr. Akin Akinyede of the Department of Pharmacology, Therapeutics and Toxicology of the College of Medicine, University of Lagos. At the end of this session, we are expected to be able to describe drug distribution in the body, make use of the concept of drug distribution in setting up experiments and research related to pharmacokinetics, unravel situations that require the concept of drug distribution. Earlier on, we are taking introduction to pharmacokinetics and drug absorption alongside routes of drug absorption alongside different routes of drug administration. In other words, you've learned that there are different routes of drug administration and that after drugs are administered, they are absorbed if given orally, intramuscularly, and through some other routes. Of course, when you administer drugs through the intravenous route, you have bypassed or circumvented absorption. And also, of course, interarticular administration of drugs, topical administration of drugs for the purpose of therapeutics do not include absorption of drugs. Having said this, after drugs are absorbed or when they are given intramuscularly, the next thing is that the drug will be distributed throughout the body. Absorbed drugs, when, for example, the drug is given orally and the drugs are absorbed through the GIT, that is gastrointestinal system, they get into the blood, and then from the blood, they are carried into different organs of the body. These drugs, as they are distributed, will to some extent end up in the interstitial and intracellular fluids. Interstitial and intracellular fluids. That is, they will end up in the fluids in different parts of the body, including in between the cells and inside the cells. When a drug commences its distribution phase, the rate of delivery of the drug to the different parts of the body where it's distributed and the amount delivered to these different parts are determined by the cardiac output, the regional blood flow, and tissue volume. The quantity of drug pumped out of the heart each time the heart beats or pumps out blood will be determined by the quantity of blood that is leaving. That is, the blood carries the drug out. And so the quantity of blood pumped out determines to some extent the amount of drug and rate of drug delivery. that we mean by cardiac output. Some organs, are better perfused by the blood from the heart. And these organs receive, a greater rate of drug delivery and a greater amount when blood flows or is pumped out of the heart. Also, the volume of different tissues, some tissues are bigger than the others, so they receive a big quantity or a greater amount of blood, and therefore a greater amount of the drug at the end of the day. So the rate and amount of drug delivered during distribution is therefore determined, or the rate of drug delivered and amount delivered as drugs are distributed are determined by cardiac output, regional blood flow, and the tissue volume. That's what I've said so far. We can clearly identify a first phase of distribution of any drug as the blood flows out of the heart. That first phase occurs within a few seconds as the drug leaves the heart through, of course, the aorta. That first phase of distribution, which spans the first few seconds, causes drugs to be distributed first, and to a larger extent, drugs to be distributed more rapidly to organs such as the liver, the brain, the kidneys, the heart. Because these are the first set of organs that blood gets to each time the heart pumps out blood. And of course, these organs also receive relatively more flow of blood in terms of regional distribution of blood from the heart. So that first phase, which spans a few seconds, delivers the drug first to organs like the liver, brain, kidneys, and heart. After that first phase, a second phase can be recognized, and that second phase requires minutes to several hours before equilibrium occurs. That second phase receives, during that second phase, blood supply is to a larger fraction of the body mass. And that second phase accounts for most of the extravascular distribution of drugs. During that second phase, organs and parts of the body which don't receive any significant distribution of drugs during the first phase now receive more significant distribution of drugs. Which are these organs that receive drugs during the second phase, in addition to the ones that are more favored during the first phase? Remember, I said the liver, the heart, the kidneys, the brain are more favored during the first phase. Now, the organs that now start to receive more blood during the second phase include organs like the muscles and the skin. And as time goes on, there's an attempt at causing an equilibrium amongst all the body organs. But this, as we will see later, may not necessarily occur fully. Diffusion into the interstitial tissues occurs rapidly because of the highly permeable capillary endothelial membrane. Now, the interstitial tissues receive drug just by diffusion, because it's like they just pass, they follow the law of mass action mainly, except in the brain, in the GIT and muscles. Why? Because the brain, the GIT, the muscles, interstitial space does not contain fenestrations or pores, whereas the other interstitial spaces of the other tissues, they contain fenestrations or pores. So the drug will just diffuse there. But for the brain, the GIT and muscles, you don't find these fenestrations or pores. So drug will not permeate into those interstitial spaces of the GIT, brain cells, muscles readily. We should also note that the ventricles of the brain contain pumps which drive drugs out. You have P glycoproteins there, and these have a pumping action. They serve as pumps. They pump drugs out of the brain. So drugs don't concentrate in the brain so easily. And of course, this can also be protective for the brain when toxic substances are in the blood. The ventral tissue distribution of drug is determined by partitioning between the blood and particular tissues, which is in turn dependent on the lipid solubility and pH gradient for weak acids and bases. Now, what I've said so far is that during the first phase of drug distribution, which spans a few seconds, most of the drug being pumped with the blood out of the heart will get first and rapidly and to a greater extent into tissues that receive better regional blood flow. The heart, the brain, the kidneys, the lungs. These ones receive better regional blood flow. But after some seconds, the drug that is being distributed will now start to get to other organs which don't preferentially during the early stages. They don't preferentially during the early stages receive much of the drug because they don't preferentially receive more of the blood flow. With time, there is an attempt at equilibrium. So other factors will now come into play because most of the organs that first receive the blood flow and therefore the drug concentration will start getting saturated. Then the difference in pH between some parts of the body and the main central systemic system. That pH difference, which anyway usually is not so much as compared to the pH difference between the fetal blood flow and the main systemic circulation. For the fetal blood, the placental blood flow, when you compare the pH with the pH of the blood in the systemic circulation, there is a bigger difference. But when you consider the other parts of the body of a human being, you forget about the fact that a woman, for example, is pregnant at this time. Normally, there is pH difference between some parts of our bodies and the central blood flow, the central systemic circulation. There's a difference. The tendency is that where in a tissue the pH is more acidic, then you expect that some drugs, depending on their level of acidity or alkalinity, will get trapped there. Though that happens, what I'm now saying is that it happens to some extent, but it does not happen so much. We call that ion trapping. It does not happen so much, but it still happens. But when you compare this to the case of a woman that is pregnant, because the difference in pH between the placental blood and the systemic blood is greater, you have more ion trapping. And with that more ion trapping, you have more drugs, more of the drug being trapped, in the placental blood and in the fetus. Later on, we'll see what happens with that. So ion trapping will occur. Then some parts of the body contain more lipids, and so lipophilic drugs tend to partition into those parts of the body. Then the bone, for example, is another organ where some drugs tend to partition. So all this will now be superimposed upon what happens during the first and second phases of drug distribution with time. So we now have a lot of factors coming into play over time. Over a matter of 2 days, over a matter of 24 hours, more than 24 hours, you have all these other factors coming into play. We've talked about ion trapping. It occurs, but it does not really occur to a large extent. But that issue of tissue partitioning of drugs occurs much more than ion trapping. Next, we consider plasma proteins. Plasma proteins are proteins found in the plasma. Simple definition. These proteins tend to bind drugs, and some drugs bind more to plasma protein than others. However, it should be noted that plasma protein binding of drugs is not so specific. Therefore, when a drug is bound to plasma protein, some other drugs that are similar or have similar binding sites may displace the other drug. Drug A binds to plasma protein. If a patient now is administered drug B, if it has that affinity of also binding to plasma protein, what can happen at times is that drug B also will displace some of drug A from the plasma protein binding site. So you have more of the free drug A in the system. The drug that is bound to plasma protein is called a bound drug. The one that is free, not bound, is called either free drug or called unbound drug. The interesting thing is that a drug that is bound to plasma protein cannot bind to the pharmacological active site, and so it will not exert the pharmacological action unless it is released from the plasma protein. So from time to time, you have some of the drug that is bound to plasma protein becoming unbound. Once the molecule becomes unbound, it goes to the active site where it's expected to act and binds at the active site and causes the expected drug action. Also, the drug bound to plasma protein cannot be metabolized. So from time to time again, you have some of the bound drugs becoming unbound and they are metabolized. Also, the drug that is bound to plasma protein cannot be excreted. Again, from time to time, you have some of the unbound drugs. From time to time, you have some of the bound drugs. That's drug bound to plasma protein becoming unbound and becoming metabolized and excreted. So you have an equilibrium reaction representing what actually happens, because what happens is an equilibrium reaction. As the drugs are being distributed, if they have affinity for binding to plasma protein, some will bind to plasma protein, some will go to some of the free ones or unbound ones will go to the active site and cause drug action. Some of the free or unbound drugs will be metabolized and therefore excreted from the system, excreted through urine, through feces, and so on and so forth. Now, the bound drugs and the unbound drug, if a drug, let's say for example, a drug A, or let's say prednisolone is administered to a patient. The prednisolone is one drug that binds to plasma protein. Excuse me. The bound drug, the bound portion is in equilibrium with the unbound portion. So as the unbound portion binds to the active site, it exerts its pharmacological action. Some are metabolized and excreted. The concentration of the unbound drug drops in the blood, in the plasma. When that concentration drops, the concentration, some of the bound drug will now become unbound to replace whatever has been cleared. They become unbound and it continues to occur like that. If perchance the concentration of the unbound one increases, for example, if a patient takes another dose of the drug, what happens immediately is that some of the bound ones, some of the unbound drug that has just got into the system will go to the plasma protein and bind them. So we have that equilibrium reaction occurring like that. We should note that acidic drugs most times we bind to albumin. Albumin is one of the plasma proteins. Acidic drugs will bind most of the time to albumin, while basic drugs will bind most of the time to alpha-1 acid glycoprotein. Alpha-1 acid glycoprotein. There are other plasma proteins which bind drugs to a smaller extent. This slide is just to recapitulate what I said earlier, that the bound drugs are not metabolized, they are inactive, and they are not excreted. Fraction of drug bound is determined by one, drug concentration, affinity for binding sites, and number of binding sites. When the number of binding sites decrease, of course, less drug will be bound. Simple mass action relationships determine unbound and bound drugs. That's what I've explained for now. Binding of drugs to plasma proteins is usually reversible, but sometimes covalent bonds occur. And you know, covalent bonds can be difficult to break. We should note that drugs may also bind to tissue constituents, and usually that is reversible. Drugs can bind to proteins in tissues, can bind to the nuclei of cells. Drugs can bind to phospholipids, including phospholipids in cell membranes, and so on and so forth. But usually, this kind of binding is reversible. Now, fat acts as a reservoir for lipid-soluble drugs. Lipid-soluble drugs have the tendency of partitioning into fat. And we should know that obese patients may have up to 50% of fat as body weight. So if an obese patient that has up to 50% of fat as body weight takes a highly lipid-soluble drug, you can be sure that up to 50% of that drug will be partitioned into the fat cells in the body. And so it means 50% of the drug will be free, that is, will be unbound to exert its pharmacological action. Meanwhile, imagine there's another person who is not obese, who has just 30% of body weight as fat. Excuse me. Such a person, extrapolating directly, will have 70% of drug unbound compared to someone that has 50% of drug unbound. It can make a difference as regards the therapeutic outcome. Then imagine a patient who is starving, a patient suffering from starvation, who has 10% of the body weight as fat. If such a patient takes the same drug, it means only 10% will be bound, will be partitioned into fat. You have 90%, free floating. So the difference between obesity and someone that is not obese and someone who has less fat may make a difference in the therapeutic outcome of drugs, because you have more drug in circulation, less partition into fat. Either is someone who has less than normal fat body fat constituent, or someone who has a normal body fat constituent. We can imagine the therapy of taupental, for example. This highly lipid soluble It partitions like some of these other anesthetic gases. It partitions into the brain. And so you have a rapid onset of action in terms of anesthesia. But the same way, because the one in the brain will be metabolized, what is left in circulation can also partition into some other tissues in the body. The concentration will drop in the system of the drug will drop in the system, very quickly. And just as there will be rapid inducement of anesthesia, there can be rapid recovery from anesthesia. Tetracycline partitions into the bone, into the bones and teeth. Radium and lead also partition into the bones. Mark you, redistribution of drugs implies what happens, which we are talking about, we've been talking about for some time. Partitioning into tissues and the drug partitioning into fat and so on and so forth. All these account for the distribution of drugs administered to patients over time, and such distribution may terminate the effect of the drug. The volume of distribution of the drug is equal to amount of drug in the body divided by concentration of the drug. Amount of drug in the body divided by the concentration of drug in the body. So it means when the volume of distribution of the drug is high, by implication, the amount of drug in the body is either very high or the concentration is not much. And perchance, the concentration of drug in the body is what, or in plasma, or in the body is what you are able to increase or reduce. It will automatically affect the volume of distribution. The volume of distribution actually is taken as the amount of body fluids of a patient, for example, that can account for the amount of drug in the person's body. So volume of distribution can be high, volume can be low. Pregnant women, for example, have an increase in body fluids. They have an increase in body fluids, especially as the pregnancy progresses. The implication is that if you administer the same amount of drug, you will administer to someone that is not pregnant, a lady that is not pregnant, to this pregnant woman. Since she has more body fluids, the concentration of drug may be less, and that may actually affect the therapeutic outcome. However, because we are careful not to cause toxicity and adverse drug reaction in the fetus, we still don't increase the dosages of drugs given to pregnant women. Anyhow, we are very, very careful. And that may account sometimes for failure of drug therapy in them, possibly. Now, when we talk about drug distribution, we talk about different compartment models. One compartment model, multi-compartment model. One compartment model, for example, assumes that Wherever the drug is in the body, in the blood, in the tissues, that it is one compartment, the same pH, the same characteristics. So you are not talking about the drug moving from one part of the body or one compartment to the other. It means you are assuming that the concentration will be equal no matter what part of the body the drug is. However, this is not true. I already mentioned about pH differences between some tissues and the main systemic circulation. Also, we've mentioned fats, that drugs can partition into fat, that drugs can partition into the bone. So we are not dealing with one compartment model, in the true life situation when we talk about drug distribution in a human being or even in an animal model that we are experimenting with. What we usually have is multi-compartment model. And clearance of drugs from the compartments, especially the single compartment model, is patterned after first order kinetics. Let's talk a bit more about the first order kinetics, zero order kinetics. Most drugs are metabolized by the first order kinetics. However, a few drugs like aspirin are metabolized by the second order kinetics. What do we mean? We are talking about the kind of reaction, we are talking about the kind of reaction. Also, not only the metabolism of drugs, the excretion of drugs can also be patterned the same way after first order kinetics or zero order kinetics. Now, what do we mean by first order kinetics? First order kinetics states that a constant fraction or a constant percentage or proportion of a drug is metabolized per unit time or is excreted per unit time, depending on whether we are talking about metabolism or excretion. Whereas zero order kinetics states that an amount of a drug is metabolized per unit time, or an amount of a drug is excreted per unit time. So it's necessary to get those clear and link them with the fact that the single compartment model is patterned after the first order kinetics. Now, these are places where drugs can partition into and linger there so that you can have more drug there, you can have less drug. But one thing we should note is that after some time of drug distribution, the drug will now start to access the interstitial space, extracellular space, and intracellular space after some time, not during phase 1, the first phase of drug distribution, and not during the early part of the second phase. But later on, we have the drug accessing the interstitial space, extracellular space, and intracellular space. For a young man, the extracellular fluid volume outside the plasma is 12 liters. That is, if you can separate the extracellular fluid outside plasma, you have 12 liters. The blood volume will be about 5.5 liters. The plasma volume will be less than the blood volume because the blood contains the plasma amongst others. The plasma volume will be 3 liters. In the blood, you have plasma, you have serum. So the plasma alone will be 3 liters, and you expect that to be because the plasma contains the cells. The total body water, the volume, total volume, such a man will be 42 liters. So we should sit back and study this more, and to give us a better idea of what we are dealing with, the implications, what can happen, and how we can influence the situation. Thank you. We've come to the end of drug distribution. Okay, maybe I should mention, I said I was going to mention more about the placenta. You know, normally we don't really want most drugs to get to the fetus. But like I said earlier on, because the environment around the fetus and the placenta blood is more acidic compared to the general systemic circulation, and the difference of the pH is appreciable. Some drugs get trapped within the placenta blood and get to the fetus and are trapped there. Now, we have P glycoproteins also, like we have P glycoproteins in the brain. We also have in that region, which pump selectively drugs out of that region, and that spares the fetus. So I think that's just what I need to add at this point. So thank you for your attention.